Welcome again to another 10 Minutes with Harry. I want to show you an electrocardiograph, which is very often misinterpreted. You can see here that the patient has atrial fibrillation with a very rapid ventricular response of maybe about 150 to 160 beats per minute. However, the ECG has been interpreted as a ventricular run or ventricular tachycardia. And what do I mean by that? Well, you can see here in yellow highlight, there is a change in the QRS complexes which mimic ventricular tachycardia. The rates in blue highlight show that the rate has increased slightly, and this is in fact atrial fibrillation with ventricular aberration. So we're going to talk today about atrial ectopy or fibrillation with ventricular aberration. To start with, we need to understand what an atrial ectopic is. It is a premature QRP, QRS, and T wave. There is a P, but this is not always seen, as it may be hidden in the previous T wave. There is a QRS, which is identical or near identical to the QRS generated by the sinus mechanism, and there's a compensatory pause. An atrial ectopic with ventricular aberration means that there is a very premature atrial ectopic, which may be conducted to the ventricle during the relative refractory period, and I will explain this in a moment. The ectopic QRS has a bundle branch block configuration, and there is a concern that this is a ventricular ectopic, or as we've already shown, a run of ventricular tachycardia. Let us now go back and have a look at a ventricular ectopic or an atrial ectopic with aberration. We can see here that there is no P wave in this case because it's hidden in the previous T wave. The initial deflections are similar to the sinus beat. We look at V1, which we do not have in this case, and it usually has a right bundle branch block. And we look for later atrial ectopics to confirm whether this is a ventricular ectopic or an atrial ectopic with aberration. So let's take this case and look at some other ectopics that occurred. You can see then that an ectopic now, which is marginally later, looks very similar, but if you look at the middle strip, you can see that the QRS is quite different. Have it a little later again, and now the QRS has become very narrowed, and there is emerging a P wave. And then another one, which is later still, and this is clearly a classic atrial ectopic and has all the hallmarks of that. Aberrant ventricular conduction results from intermittent, uneven physiologic refractoriness in the ventricular conducting system from a very early supraventricular beat. As I stated, there is QRS widening consequent to a delay or block in one of the bundle branches or a more peripheral branch. This highlights what aberration is all about. To the left, we can see two action potentials, one from the left bundle branch and one from the right bundle branch. Usually, the right bundle branch action potential duration is longer than the left. So we can see, as highlighted, an absolute refractory period above with the left bundle branch and another one which is longer with the right bundle branch. During the phase 3, you can see, which is red highlight, that This period is a relative refractory period, and for the left bundle branch, it is in the refractory period, whereas with the right bundle branch block, it is in the absolute refractory period. So there is a short period in the action potential where the left bundle branch will allow conduction and the right bundle branch remains an absolute refractory. So in summary, on the right bundle action potential is usually longer. Premature beats may be conducted during this relative refractory period of the left bundle branch. QRS widening with right bundle branch configuration therefore occurs. Here is a classical atrial ectopic with aberrancy. It is usually in V1 that we see the P wave, the wide QRS, and this is a right bundle branch block. And the features are that of an RSR pattern, which is often called rabbit's ears. Aberration was first described by Gill and Ashman in 1947. It was in relation to atrial fibrillation and is now called the Ashman phenomenon. I often wonder why it's not called the Gill phenomenon, but I suspect that people couldn't pronounce Gill's name and therefore Ashman gets all the accolades. It occurs with atrial fibrillation, often with a rapid ventricular response. There is a right bundle branch morphology, a right bundle branch block morphology, and there is a long cycle, short cycle. The relative refractory period depends on the cycle length of the preceding cycle, and that's what long cycle, short cycle means. Let us have a look at the illustrations on the right. There are two with rabbit's ears. Although this is atrial fibrillation, one can see both in V1 that there is an RSR pattern, and this would be consistent with aberration. When one talks about long cycle, short cycle, you can see here that there is the long cycle and then the short cycle. The long cycle does set up the refractory period of the QRS immediately before the aberration. So that is why the long cycle makes the action potential a little longer and allows therefore a short cycle QRS to come out as aberration. You can see this in both of the cases. It can also result in left bundle branch block, even in the same patient. It can occur in series, such as couplets, triplets, and runs. And because it's atrial fibrillation, it may not have a compensatory pause. The QRS of Ashman phenomenon is generally narrower than with a ventricular ectopic if you look at all leads. Have a look at this electrocardiograph, and you can see that on the left there is an atrial ectopic with a normal QRS. To the right, however, one can see that now it is widened, but it's particularly widened in V1 with an RSR QRS, but whereas in V6, it looks very much like the narrow QRS that was shown in the red highlight. This highlights, in fact, the fact that an atrial ectopic with aberration may in fact have a narrower QRS than a normal ventricular ectopic. We now go back to the slide that I showed first up and have a look and see the tracings in the same patient, atrial fibrillation, rapid ventricular response, and we can see that in all the cases, it's been labeled as a ventricular tachycardia or a ventricular run, a V run. you can see that here with the yellow highlight, it is a classical right bundle branch block in that the middle tracing is a V1. Now looking at the one on the right with the blue highlight, you can see that now this is a classical left bundle branch block. Same patient and only some period and time between them. And then having a look here, you can see that it can change from right to left within a few beats. Here is another example of atrial fibrillation with a run of aberrant conduction. And another one here where you can see the onset of atrial fibrillation is very rapid to begin with. And then as it gradually slows on the bottom line, one can see that the QRS now becomes narrower. So this is a classic presentation of ventricular aberration and should not be misinterpreted as ventricular tachycardia. Here is an atrial triplet on the right with varying aberration. Have a look on the left, we can see an atrial ectopic. Then in the triplet, we can see two QRS complexes with rabbit's ears, which are classical aberration. And then there is somewhat of a pause and no aberration. And so this clearly shows the differences between aberration and normal conduction. And finally, I'd like to show an interpolated atrial ectopics with aberration. And you can see here, they most certainly look like ventricular ectopics, but because of V1 with the RSR pattern, one can assume that these are in fact atrial ectopics. Thank you.